So I am Katie Sims. I'm one of the field clinical with Inspire. This is Morgan.
I am the rep here with Blunt Memorial.
So we are with Inspire. Does anybody know what Inspire is or what it's used for? Yes. So, okay, we are an option for people that cannot tolerate the CPAP. So what we do is we do an implant, and you're going to have 2 incisions. You're going to have one on the neck and then one on the chest. We have 3 different implantable devices that we put in. The first thing that we're going to put in is the stem cuff. It's this piece right here. It's kind of like a slap bracelet that has 3 little electrodes on it, and it'll go on the hypoglossal nerve, and then we tunnel it down through to the chest. So during the surgery, what we're going to do is we're going to test the nerve and see which part of the nerve helps the tongue stiffen and go forward. And then there's also retractors that will actually pull the tongue back. So what the physician will do is separate the nerve and find that break point so that we can put exactly what we want within the cuff. And then that piece will tunnel down to the chest. We'll have another incision there, and we have 2 pieces that go there. This is the IPG, the battery. It lasts 11 years. And then both of the stem cuffs will plug into that, or the sense lead and the stem cuff, I'm sorry. This is the sensor. So this is gonna go in between the external and internal intercostals. It's gonna sense each breath that the patient takes, and then it's gonna stimulate the tongue to move up and out of the airway. So it does not actually detect apnea and then treat. What it's gonna do is, with every breath, it's gonna move the tongue out of the airway. So do y'all have any questions about anything? Anesthesia specifically, some things that we like are no long-term paralytics. We want the tube to go out to the left because we typically do our implant on the right. Not that there's anything wrong with doing it on the left, we just prefer to reserve that for a pacemaker if they have that. And they can have both. They can have a pacemaker and this. They can have other generators or implantables. It just needs to be at least 6 inches away.
If they're having another surgery, do we need to turn these off if they're having some other surgery?
It will be off. They only turn it on whenever they're asleep. So the patient will get this remote, and it's not activated or turned on until 4 to 6 weeks later. And they'll get this remote, and what they'll do is every night they'll boop, push the button. It'll have a delay. Typically it's 30 minutes, but we can change that. And then they'll fall asleep. It'll run for 8 or 10 or however long they sleep, and then when they wake up, they turn it off. So it will be off. When it's on, some things, if a patient tries to talk, like if they wake up in the middle of the night, they'll have slurred speech and their tongue will, so we always say you can pause it in the middle of the night if you need to talk, eat, sip of water, something like that. So, but as far as anesthesia, we just say tube off to the left. We don't want the tongue caught because we're gonna do the testing in the OR, and we're gonna make sure that the tongue is going forward. Any other questions? As far as recovery, it's a pretty easy recovery. They can eat and drink later that day. They can take a shower the next day. There's no restrictions with food. Some people do pain medicine and nausea. Some people just do over the counter. So overall, it's a very easy recovery. They don't have to have a sling like with a pacemaker. They're able, we normally say no big motions like chopping wood, golfing, fishing for a few weeks. Chopping wood, we did have a guy that chopped wood the next day, even though we said not to, and it got infected. So that doesn't happen very often, but we do typically say, no big motions like that, because obviously you want it to heal and you don't want it to open up or anything. So this part of the area, a lot of people like to get out and chop wood, and so.
And when they're having this done, you're here, one of you guys are here every time.
Absolutely.
Yep.
So we're here at every case. We will have a trainer come in for the first few cases with Dr. Tigner, and then we will always be here because we run testing during the surgery. We want to make sure that it's working perfectly, and then they get it turned on 4 to 6 weeks later at the sleep clinic. So Claudia over at the sleep center already manages. She has about 11 patients, and then Dr. Duvall and Brandon here at the hospital, they have close to 25 or 30 patients. So it's turned on 4 to 6 weeks later, just because we want the nerve to heal. But we will run the testing during every single case to make sure it's doing what we want.
And I'm sorry, Katie, can you talk a little bit about what the pre-requirements are, the DICE?
Yeah, absolutely. So before someone can get a DICE, the requirements are it needs to be moderate to severe sleep apnea, meaning at least 15 times they stop breathing per hour. So 15 up to, we just got indication up to 100. So you might have seen the old recommendation, and that was up to 65. So depending on the insurance, some of them don't have an upper limit cap, but as far as the Medicare, it's 15 to 65, and we're waiting to see if they've changed up to 100 because we got that indication last fall. And then, so they need to have moderate to severe sleep apnea. Their BMI needs to be less than 35 if it's Medicare. Some other ones it's 32. We did get indication up to 40, so we're kind of working through some of that. And then they need to have obstructive sleep apneas, not mixed or central. It has to be less than 25% of those so that we can actually work with that. And then if they qualify that way, what we're gonna do is we're gonna do a DICE procedure. And so that's a very quick procedure that we do, and we take a flexible scope, we go through the nose and just look at the velopharynx. So what we're looking for there is the way that the airway closes. So we want an AP collapse of the airway, and that is because we know our device is gonna move the tongue forward, so we wanna make sure the soft palate comes with it. The other collapse that can happen, it's called a concentric collapse, and it almost looks like a purse string, and that's where the lateral walls will collapse and almost kiss. And if that's the case, we know that our device isn't gonna be successful because we're moving front to back. So what we do in the DICE is we place a flexible scope, and we just go to the very top of the airway, and we're making sure we have that collapse pattern. We don't go any lower than that. The procedure itself is very quick. We normally just do propofol on a pump and just watch very slowly. And the reason we ask for a pump is because we don't want to oversedate. If we oversedate, it will make it look like they have concentric collapse. So I like to think of these patients as, you know, they've tried the CPAP, they've done everything, there's not really any other option. So 80 to 90% of patients with a DICE are candidates. And we have a lot of patients out there that we're trying to help in some way. The side effects, if they don't treat sleep apnea, you know, stroke, heart disease, different things like that. So if you're not treating it and you're stopping your breathing, then this is kind of, I don't want to say the last resort, but we do like to look at the DICE and make sure that it is appropriate. So that's why we ask for the pump, because if you oversedate, it can make it look like they're not a candidate when they really are. So.
Anybody have any other questions? Well, thank you so much
All
for
right.
coming. We appreciate it.
Thank you.